Non-rebreather masks. A non-rebreather mask has ports on the side that are one-way valves that allow CO2 out, but keeps the patient from breathing in any room air. This increases the O2 delivery. So non-rebreather mask is your highest O2 level. It can deliver an FI2 greater than 80 to 95% at 10 to 15 liters per minute. It's used for your unstable patients requiring intubation. So if they're waiting on intubation or they definitely are not getting enough oxygen and it's something that patient's probably going to need, that non-rebreather is where we're going to go right before we intubate. You want to ensure that valves are patent and functional and that bag should be 2/3 full. Next, we'll talk about high flow oxygen delivery systems. High flow can deliver 24 to 100% at 8 to 15 liters per minute. So high flow includes venturi masks, aerosol masks, face tents. We have the use of vapotherm. Vapotherm is a heated, humidified air. It helps facilitate secretion clearances. This decreases the risk of bronchial hyperresponse syndrome or that bronchospasms you'll hear occasionally. Then we have high flow nasal cannulas, tracheostomy collars, T-pieces, and oxygen hood for infants. Vasotherm and high flow nasal cannulas are frequently now being used. They just really help with that, that humidified and obviously the warmth from the vapotherm. And then phase tense is a high flow, but it decreases that level of room air being inhaled as well. Venturi mask. A Venturi mask mixes oxygen with room air and it creates a high flow enriched oxygen of a desired concentration. It provides an accurate and constant FiO2 despite varied respiratory rates or tidal volumes. So the important thing to remember about a Venturi mask is it delivers precise O2 concentrations. So 24 to 50% is the FiO2 at 4 to 10 liters per minute. This is the best device for chronic lung diseases. Adapter is located between the bottom of the mask and the O2 source, as you can kind of see in that picture. Venturi mask allows PO2 to be titrated. This minimizes the risk of CO2 retention. And then you want to switch your patients that are on a Venturi mask to a nasal cannula during meal times. But the biggest takeaway from a Venturi is that it is precise O2 concentration. T-piece. A T-piece is an apparatus for attachment to an endotracheal or tracheostomy tube. It delivers desired FiO2 for tracheostomy, a laryngectomy, or ET tubes. It ensures humidification through creation of mist, and the mist should be seen during inspiration and expiration. So that's something to monitor as the nurse, that you're seeing that mist. Non-invasive positive pressure ventilation, or NPPV, uses positive pressure to keep alveoli open, improve gas exchange without airway intubation. So these are your CPAP and your BiPAP. These deliver set positive airway pressure throughout each cycle of inhalation and exhalation. So they're set. Can be used with O2 or without O2. This can be either a full face mask or just a nasal. It opens collapsed alveoli. It's used for atelectasis after surgery or cardiac-induced pulmonary edema or sleep apnea. So first we have a CPAP, or continuous positive airway pressure. This is only one pressure and it acts like a splint to keep airway open, and it's the exact amount of pressure continuously. Then we have a BiPAP, or bilevel positive airway pressure. This you have two pressure settings, one for inhalation and one for exhalation. Can also be set to include a breath timing feature. If time between breaths exceeds a limit, it can force a breath. Will be used, or it can be used, can and will be used for patients who come off of vents. Patients may be on routinely, and if they are on routinely, typically they can be on a med-surg floor with their BiPAP if it's something that they're doing every night. Otherwise, usually you will see this in the ICU. Okay, so here you'll see different delivery systems for that positive airway pressure. The first one on your left, this subject is wearing a nasal mask and headgear with positive airway pressure being delivered. Positive pressure is delivered only to the nasal airway. Opening of the mouth may cause air to leak and decrease the efficiency of the positive pressure regimen. The gentleman in the middle, he's wearing a nasal, what they call nasal pillows. This is positive pressure is delivered directly into the nares rather than covering the nose or mouth. Only minimal headgear is necessary to anchor the interface in place. And then the last, farthest to the right, he's wearing a full face mask. Positive pressure is delivered to both the nose and the mouth, and this is based on the subject's own breath-to-breath partitioning of nasal and oral airflow. Transtracheal oxygen delivery, or TTO. This is an oxygen therapy. It's a method used to deliver oxygen directly to the lungs. It is used to treat chronic hypoxemia. It's a small plastic catheter that's surgically placed in the patient's neck and sits in their windpipe or trachea. This is long-term delivery of O2 directly into the lungs. It helps avoid irritation from nasal prongs, so they might opt for this. And then it's just more comfortable for this type of patient. The flow rate prescribed depends on if it's rest or activity, so those things will be adjusted depending upon what their need is. Home oxygen therapy. So there's criteria for equipment. For Medicare to pay for oxygen at home, their O2 sats have to be less than 88% on room air. So there's definitely some criteria. There's different equipment. They can go home with a compressed gas in a tank or cylinder. They can have liquid oxygen in a reservoir, or they can have an oxygen concentrator. Either way, you want to do patient education for use and safety. So things like don't use oil or grease or Vaseline or any other flammable substance with their oxygen equipment, either on their skin or around that equipment itself. You only use water-based products. You want to talk to them about open flame or heat sources such as candles or gas stoves, anything that could cause a spark. Definitely do not smoke or let anyone smoke around your oxygen equipment. So things like that for safety, especially for patients that are their first time going home on oxygen therapy. Okay, tracheotomy. This is a surgical incision in the trachea for the purpose of establishing an airway. And then tracheostomy is the stoma or opening that results from a tracheotomy. This tracheostomy might be temporary or permanent. And then possible complications of a tracheostomy would be a pneumothorax, subcutaneous emphysema, so that air trapping under the skin, any bleeding from that procedure, and infection. Tracheostomy tubes, so they can be either disposable or reusable. There's cuff tubes or tubes without cuff for airway maintenance. The cuff prevents air from escaping out of the mouth and nose. It's needed in ventilated patients or those that are at risk for aspiration. There's an inner cannula that is both disposable or reusable. And then we have a fenestrated tube. The fenestrated tube is a hole in the shaft of the tracheostomy tube. It's above the curvature and therefore also above the cuff of a cuffed trach tube. The purpose of a fenestrated is to allow for airflow upward and through those vocal cords. Without an airflow through the vocal cords, a tracheostomy patient will not be able to produce a voice. The fenestrated is not necessary to be able to talk with a tracheostomy tube, although it will likely improve the loudness and ease of producing a voice for those patients. So care issues for a patient with a tracheostomy. We really want to prevent tissue damage. So you want to be monitoring your cuff pressure that can cause mucosal ischemia. Use minimal leak and occlusive techniques. You want to be checking that cuff pressure often. You want to prevent tube friction and movement and prevent and treat malnutrition, making sure that your patient is hemodynamically stable and prevent hypoxia. With tracheostomy care, you want to be assessing your patient. The priorities of care is to oxygenate your patient and make sure they have a patent airway. You want to be communicating everything that you're going to be doing with that patient and secure tracheostomy tubes and making sure that they're in place and prevent accidental decannulation. Air and warming and humidifying. So remember, a tracheostomy tube bypasses your nose and your mouth. And like we discussed earlier, that your nose and your mouth is where we humidify and warm and filter our air. So air must be humidified. You want to maintain proper temperature for that air and ensure that your patient is having adequate hydration. Some complications. So your patient can develop tracheomalacia. This is caused because of constant pressure exerted by that cuff, and it can cause tracheal dilation and erosion of the cartilage. Your patient could develop a pneumothorax. This can develop during the tracheostomy procedure if the thoracic cavity is accidentally entered. They can develop subcutaneous emphysema during that tracheostomy procedure if air escapes into fresh tissue planes of the neck. And then they can develop something called trachea innominate artery fistula. This can occur anytime it develops or is caused from a poorly positioned tube, which causes its distal tip to be pushed against the lateral wall of the tracheostomy. The results of this is it's rare, but it is life-threatening. Suctioning. So why do we suction? We suction to maintain a patent airway and to promote gas exchange. We need to assess the needs in patients who cannot cough adequately or they cannot just get that sputum up, so we might need to assist in that. Suctioning is done through the nose or mouth. Complications of suctioning is hypoxia. We could cause tissue trauma to that mucosa. The only time we suction is on the way out, not on the way in. We can cause infection. We also can cause vagal stimulation or bronchospasms. Vagal stimulation may occur during suctioning and result in severe bradycardia, hypotension, heart block, ventricular tachycardia, or asystole or other dysrhythmias. If vagal stimulation occurs during suctioning, you need to stop suctioning immediately and oxygenate your patient manually with 100% oxygen. Repositioning the patient, slow deep breathing, and coughing will not address the cardiovascular effects of vagal stimulation. Cardiac dysrhythmias from induced hypoxia include bradycardia, ventricular tachycardia, and asystole. So suctioning can be very dangerous. You just need to be mindful of those complications. Causes of hypoxia in a patient with a tracheostomy. These are caused by ineffective oxygenation either before, during, or after suctioning. The use of a catheter that is too long for that artificial airway. Prolonged suctioning time, so only 10 seconds at a time is what you need to be suctioning. Excessive suction pressure and too frequent suctioning, if we're suctioning too frequently. Bronchial and oral hygiene or pulmonary toilet. So what is pulmonary toilet? This refers to exercises and procedures that help to clear your airways of mucus and other secretions. This ensures that your lungs get enough oxygen and your respiratory system works efficiently. So what can we do, or what can we encourage for our patients to do this pulmonary toilet or this hygiene? We want to turn and reposition them every 1 to 2 hours. And we want to support out of bed activities. So really pushing them, if we can get them out of bed, if we can get them to ambulate, encouraging early ambulation. That's what we really want to see. But if they are not ambulatory, that we're turning and repositioning them every 1 to 2 hours. That helps with that oxygenation. We want to encourage coughing and deep breathing, the use of that incentive spirometry, possibly chest percussion or vibration, and postural drainage promotion. All those things will help keeping that airway clear and good for oxygenation. We want to avoid glycerin swabs or mouthwash containing alcohol for oral care, and you want to be assessing for ulcers, bacterial, fungal growth, or infection in that mouth. Nutrition with tracheostomy. Swallowing can be a major problem for patients with tracheostomy tubes. If the balloon is inflated, it can interfere with passage of food through the esophagus. What we can do as the nurse is we elevate the head of the bed during meals and at least 30 minutes after eating to help prevent aspiration during that swallowing and then afterwards as well. Weaning from a tracheostomy tube. So weaning is a gradual decrease in tube size and the ultimate removal of the tube. A cuff is deflated when a patient can manage their own secretions, and that patient does not need assisted ventilation. You will see them being changed from a cuff to an uncuffed tube. The size of the tube decreased by capping and the use of a smaller fenestrated tube. Tracheostomy button has the potential danger of getting dislodged, so that's something that they are mindful of as well. The answer is false. The rationale: flammable solutions containing high concentrations of alcohol or oil are not used in rooms in which oxygen is in use. However, this does not include alcohol-based hand rub. Okay, the answer is B, tracheomalacia. The rationale: tracheomalacia can develop because of the constant pressure exerted by that cuff, causing tracheal dilation and erosion of cartilage. Pneumothorax can develop during any tracheostomy procedure if the thoracic cavity is accidentally entered. Subcutaneous emphysema can develop during any tracheostomy procedure if air escapes into fresh tissue planes of the neck. And trachea innominate artery fistula can occur anytime a malpositioned tube causes its distal tip to push against the lateral wall of the tracheostomy. The answer to question 3 is C. You want to oxygenate the patient with 100% oxygen. Rationale: vagal stimulation may occur during suctioning and result in severe bradycardia, hypotension, heart block, ventricular tachycardia, asystole, or other dysrhythmias. If vagal stimulation occurs, Stop suctioning immediately and oxygenate the patient manually with 100% oxygen. Repositioning the patient, slow deep breathing, and coughing will not address the cardiovascular effects of vagal stimulation.